All right. So I'm Tracie Rosser. I'm from Emory University, which, if you do not know where that's located, is in Atlanta, Georgia. And I just wanted to first say thank you to Dr. Jackson Cook and the IMDSA organizers for inviting me today. It's a great honor to be here. And can we just give them a round of applause? Because I think this has been an amazing conference. I mean, you guys have done a fantastic job over the last few years. So thank you so very much. So I'm going to tell you a little bit about one of those databases that we were just talking about, that data is being shared through Include and with one of our projects, the DSCHD study. But I'll tell you a little bit about the history of, like how we started the database originally and where we are today. But before I do that, a special thanks, because again, we would not be here if it were not for the participants and families. So we cannot, any of the researchers that you've heard from in the last 2 days, we couldn't do what we do if it wasn't for you guys. So a big special thank you to that. A special thank you to my mentor, Stephanie Sherman. Some of you may have heard of her. And she has retired from Emory, and we are taking on her legacy. And then I've got two of my team here with me today, Helen Smith and Alexander Leon, who's in the back. So a big thank you to them for attending today. So just to give you a little bit of history about Emory. So the Down Syndrome Center at Emory, we first started doing research and collecting information on families with Down syndrome back in 1989. So we have been around for quite some time. And as Colleen mentioned, research is slow, so it takes a long time to build up these databases. It takes a long time to collect all this information. There's a lot of things that we learned that you would say are more along the lines of negative research. We can tell you a lot of things that don't cause Down syndrome, but we're still looking to answer some of those major questions, even from when we started back in the 80s. That project went on for several years, and then we launched the Congenital Heart Defect Study. And then we followed that with the National Down Syndrome Project. We opened our first Down syndrome clinic in 2003. And then we expanded to the Emory Down Syndrome Project, which at that time we were able to use online resources. So no longer did anyone have to actually come to Atlanta to be able to do the study. We could coordinate blood draws using FedEx and, having you just do a simple piggyback draw on an annual thyroid stick. And we could do our surveys over the phone or online. So it changed how we were able to expand to basically all over the United States. We expanded the CHD study. We enrolled other groups in that we followed that with a Down syndrome cognition study, which was looking at how kids learn and process information. And we were also within that study, we were hoping to define some of those measures that could be then used in clinical trials. Because as you've heard, it's very difficult to be able to track how well an individual does on testing if the tests that are out there, your kid just hits the floor. So we were trying to define some of those measures so that they could be used. You can't really tell if a potential medication is actually helping if you're still at the floor and you're not able to actually register that expansion and ability to do better. We did an expressive language study in 2014, launched a medical questionnaire follow-up study, and then the DS360 program launched that you just heard about a few minutes ago. Life DSR. We're currently now looking at a Down syndrome ASD study, and we're involved with one of the leukemia studies that you heard about earlier that's coming out of Baylor. So just to give you a little bit more idea of how expansive these were, when we first started with the Atlanta Down syndrome study, that was just a 5-county metro area study. And one of the reasons we did it that way is we wanted to do a true epidemiological study to understand prevalence of some of these conditions. And that meant that for those 5 counties, we went and we talked to every single family that had a child born with Down syndrome. We tracked them down, we got their information. And that way we could really understand more about, how, often do heart problems actually occur and which type of heart problems actually occur. Because if you just do a random sampling of the population, you really don't understand those true prevalence rates. Now, I'm going to show you some graphs later in the presentation. Some of those are based on these studies. The ADSP and NDSP was also that where we got, every kid in that area. And then some are not. Some are based on just the families that have participated in our individual studies and, completed our surveys and done this research. So that means that it may not be generalizable to everyone who has Down syndrome. So these again are just a few of our studies and where they're located. The Down syndrome ASD study is enrolling right now. It's based out of University of Illinois. And the enrollment is nationwide. Again, it's online, so you can do surveys and Zoom meetings with the investigators. And then the Baylor study is launching hopefully in the next year. So I think you've heard over the last 2 days, it's very important to have diversity in your research. It's also important to have diversity of the samples that you're collecting and the diversity of the data types. So we've collected survey data, samples, we have the whole genome sequencing, medical records, and then the cognitive testing. And you can kind of see our numbers here. We have closer to probably 4,000 participants in the database, but about 2,700 are still active at this point, engaging with us. When our participants share data, and I think this is really important whenever you guys start looking at research studies, as you know, we were talking earlier, you want to make sure that that data is going to be shared. You want to make sure that it's going to go into a resource that's going to help other families, and it's going to be put to the best use. So our families, when they consent to do any of our studies, they agree to share all of that data with future researchers that are looking at problems related to Down syndrome. Now that means it's related to Down syndrome, right? We're not looking at knee replacements or something like that if it's not related to our families. All of that data that we share is de-identified. You want to make sure that there's privacy in place and that you're, following through on those. And you want to make sure that whatever study you're looking at doing is IRB approved. You want to make sure that, somebody has taken a look at the study and given it that stamp of approval to make sure it's really appropriate. So just kind of keep that in mind as you hear about studies and think about what you might want to sign up and do. That's not anybody that's here. We're all good here. But just as you go out into the world and you're approached by other things. So just to give you an idea of our survey data, so we do maternal interviews. Those are collected usually around the time of birth, although we do those later. It's just a recall factor at that point, because we do ask a lot of questions related to family history, medical history. We were trying to capture environmental exposure, so we asked questions related to things like smoking around the time of pregnancy and alcohol. And I can tell you, neither one of those increase the risk of Down syndrome, so no worries there. Again, I can tell you a lot of things that we found that don't impact, just not a lot that have. We do paternal interviews, which also collect information on the dad's side of the family. We did a cognition survey specific for those families that were involved in that project that did background history and some early life experiences. We wanted to know, how different types of therapies these children had, and could those, early speech therapy or early other therapies, could that impact how well they were doing on some of these cognitive testings? How often do they play video games? Were they experienced in using an iPad? Would that also then help them do well on some of the testing that we were doing that was on a computer? And then I mentioned right now we're doing a medical follow-up questionnaire. And that's because a number of these families, they participated really early in life. We were getting them right after birth, or we were getting them while they were having heart surgery during that first year. So we want to go back now and find out, okay, are you having GI problems now? Are you having sleep apnea now? So what's going on that's occurred in the last 5 or 10 years that we may not know about? Because we need to supplement that information so that then when we do use it in these databases, we have a more full picture of everything that's going on in that family. Okay, so to just give you an idea on the different types of samples we have, or that you may be asked to do in the future for whichever studies you want to do. We collect blood. Again, we usually do that as we piggyback on a thyroid test. So we may wait a year before we get a blood sample because we know that sometimes it's very traumatic, very stressful to get blood samples. Sometimes kids are just fine with it and it's not a problem. We also can do saliva kits. If the child is old enough that they can spit in a little cup. And if the kid's really, really young, we've done buccal swabs, but we're able to get the DNA that we need from those, you know, to do the whole genome sequencing and do the other assays that we're doing. One of the hardest things we do is collecting the medical records. And that's because people move around and they see different specialists and they see different primary care physicians. But we want to have that true medical record. We don't want to just pull from an ICD-9 code because, as you know, they were talking earlier that, you know, sometimes you may have 9 or 10 of those, and we want to go to the source and we want to actually get the real record. Things like medications. I mean, if you just look in medical records, sometimes it'll say, you know, a child's taking this, this, and this for medications. They're really not, you know, so we also get parent report, we get caregiver reports, so we can match those up to really try to understand what's going on. So this is just an example of, you know, some of the medications, some of the medical records that we get. Once we get those in, you have to abstract them all. So we have to go through, we de-identify everything again. So we take off all that information. We put it into a database and then we put it into an abstraction form that's easily shared among researchers. So if we have somebody who comes back and says, hey, do you have any families that have Hirschsprung's disease? I can immediately go to my database and say, yeah, you know what? We've got about 30 families that have Hirschsprung's disease. So what would you like to know? You know, so we want to be able to have that information easy to access. This is an example of our cognitive testing battery. We are currently analyzing all that data. We're hoping to start doing some additional testing when the leukemia study starts, because we're going to do controls for that study. So our kiddos will be ones that have Down syndrome but don't have leukemia. And then just to give you an idea of, is our database kind of representative of what you see in the population, right? So we're about 50% between male and female. Our age range, the majority of our participants in our study are between the ages of 10 and 20. And that's mainly because we had those really two large studies, the ADSP study and the NDSP study, when we collected just thousands and thousands of participants. And then what are our frequencies? So as I'm sure you're all aware that, you know, estimated frequency of mosaic Down syndrome, about 2% maybe. We see exactly right at, you know, about 2% in our database of our families that have mosaic Down syndrome. We looked at gestational age because I thought you guys might be interested to know, like, are kids born more preterm if they have Down syndrome? The frequency of a preterm birth with Down syndrome is about 20%, which is above what you would have in a non-Down syndrome birth, which is about 10%. And in our database, we see about 20%, 26% of our kiddos have preterm. And preterm, I'm saying here, is earlier than 37 weeks. And these numbers are exactly the same between our mosaic families and our standard trisomy 21 families. So we don't see any difference there between the types. And then we've heard a lot about diversity. And again, you know, we're not where we need to be with this. But I just wanted to give you an idea of what, you know, our database looks like with our family diversity. So we're running about 60% Caucasian. We have about 18% Hispanic and about 11% that identifies Black. And these are self-identification. We take what race is reported by the caregiver. And just to give you an idea of what that looks like compared to diversity across the United States. And these are census information from 2010 and 2020. And you can see we're right there. I mean, so the population of the US is about 60% Caucasian, about 19% Hispanic, and about 12% Black. So we're right in there with the typical population on our database. So then I want to tell you a little bit about the congenital heart defects and what we've seen with those. So as you've all heard, you know, kiddos with Down syndrome have a much higher risk of heart problems, and they have about a 2,000-fold increase over a specific type of that, the ABSD. So we certainly, database is a little bit skewed now at this point because we have collected so many families with heart problems. And we see a large number of our families do have the ABSD or either an ASD or VSD. Now the PDA and PFO is one of those that could go either way. Some caregivers will say, oh, my child had a heart problem because they had a PDA. And others will say, oh, that's just a normal variation, especially if you're born preterm, because a lot of times you'll have that hole in the heart right up until you're born and then it closes. But some of the families, it doesn't close on its own, so they have to actually go in and do a ligation and fix that hole in the heart. So it's a little bit more serious than what I would call a no CHD, right? So I like to separate those out, and whoever is using our data for data analysis certainly has the option to plump them back in as the no CHD if they'd like to. And then I broke this one out because this is one where we actually have enough data on our families with mosaicism to be able to see the difference in the rates there. So again, you have to keep in mind our numbers, right? You know, we only have about 75 families with mosaicism versus, you know, a lot that don't. So, but still, this is based between those families that are mosaic, and you can see they do have a lower percentage of heart problems in those families. One of the other interesting things about CHD is it has a difference in sex ratios. So in the past, it's been closer to a 2-to-1 ratio with ADSD, with female to male. We're not quite seeing that now as we've collected more and more families. And I don't know if that's anything that's changing over the years or if it's just a matter of how we're, you know, bias selection in our families that come in and participate. The flip side of that is VSD. So VSD, it actually occurs more often in males than it does in females. And we still don't understand why there are those gender differences between the two types of heart problems. Another one is race. So again, we see a difference in the heart problems depending on what the ethnic background is and what the ancestry is. So you can see that white and black have a much higher rate of AVSD, whereas families that self-identify as Hispanic have a higher rate of VSD. And then those that are Asian, which we don't have very many, but we still see a less difference between the different types of heart problems there. So this is just a really simple kind of summary of that. So for AVSD, you see a higher increase with females and black or white ancestry, and VSD is male or Hispanic. So again, I think this really just tries to explain why we need to have the diversity so that we can see these differences, and then we can try to tease them apart and understand like what is going on. So why would there be a sex difference? Why would there be a race difference in something this is, you know, you would think is consistent at the heart developing, right? That should just be set to go. We also looked at GI and structural ongoing issues. This is one where we have much fewer individuals with GI issues. So we only had about 963 that actually even responded to the GI question. And out of that, 9%. So they had a structural problem. And usually these are identified immediately at birth. So surgery is completed before they ever leave the hospital. But one of the things I thought was really interesting is that our families are really reporting a lot of those ongoing GI issues. So this is happening, you know, after surgery to correct those initial problems. But this is affecting like almost 50% of our families. And if you guys have had to deal with kids that have chronic constipation or reflux, you know, it is a problem. It's a serious problem. It affects behavior. It affects their lives in a lot of ways. So it's not something that could just be corrected at birth and moved on. This is an ongoing, lifelong problem. So there were only 2 types of GI issues that I could actually have enough that I could break out by sex and by race, and those were duodenal atresia and Hirschsprung's. Duodenal atresia usually is about a 50% between male and female, and we see that here. And then with Hirschsprung's, you often see that occurring more in males than you do in females. And again, we don't know why just yet. And then you can see again that there are some racial differences here as well. So this is a compilation of our database as well as some of the previous studies. So you can see again, one thing that I didn't discuss here is influence of maternal age. but we have seen that that also plays a role in some of the GI defects as well. And then, of course, the ancestry of the sex. Now, these next two that I'm going to show are fairly recent, and we just started looking at this because, again, I said we're going back to do those medical questionnaires with all of our families. So things like endocrine and sleep apnea, those type of issues occur later in life, right? So we're in the process of going back and recontacting families and getting information. So I think we have about 300 surveys at this point. So we still have a ways to go, but as you can already see that we do see some differences between an endocrine here. I'm reporting majority's hypothyroidism because we know that's it, but this also hyper. We've got a few Graves' disease, Hashimoto's, and then a few that are diabetes, but I would say the majority here is hypothyroidism. You definitely can see a difference in the race. And possibly we might be teasing out a little bit of a difference between our families that have mosaicism and those that don't. Looking like that it's, more that have hypothyroidism or endocrine problems. But again, this is just very preliminary and we need to do some additional studies on this. The other one is sleep apnea. And with both of these, it also brings to mind things along the lines of health disparities. So I think that's another way to look at this. So just because we're seeing a difference in race may not mean that it's a genetic difference in race, right? It may just be that we're seeing a health disparity difference in race, and that certain families may not be referred as often, or they may not be getting the treatment as that they need, or maybe, the insurance is not covering the sleep apnea treatments that they would need. But all of this, I think, is intriguing, and it's something that we definitely want to start exploring more. And then I think we've all heard that, Down syndrome is this compilation of so many medical conditions. And we talked about the possibility of those interplaying on each other and are they interacting with each other in the last talk. So I just wanted to kind of give you an idea of where our families are reporting. And most of them are reporting, 3, 4, 5 conditions. So it's not just one thing. It's multiple body systems that are being affected and that they're having to deal with those conditions and treatments. So this is kind of just my summary of some of the things that we know about how race and ethnicity plays a role. Again, there's a higher incidence at birth if the family is Hispanic and a lower life expectancy if the family is in Black. And then in between, we have all these other things that are happening with the different types of medical conditions and how those interplay with both sex and race. We've heard this already, so I won't spend too much time on this, but I do think it's important to consider, how diversity is involved. And again, it's not just those genetic differences, but it also can be those health disparity issues. I also wanted to touch briefly on the barriers to participate. I think IMDSA does an amazing job with this retreat every year to give families the opportunity to have research studies come to you guys and do that. Of course, the pandemic has somewhat changed what we used to have to do. A lot of things moved online, so there's options out there. Just again, be careful and evaluate what you guys are involved in. But we know it takes a lot for the families to be involved, and we're very appreciative of that. Incentives, we try to do what we can, but also realize those are mandated on the back end by the IRB, because we also can't induce you to participate. So we can't give you thousands of dollars to be in our research study, because you have to have self-choice to be able to decide what you want to do. Information learned. You really want to make sure you're going to get that information back from the studies that you're going to be in. It may not be groundbreaking, it may not be super exciting because research is slow, but you should hear from those researchers at least once a year in a newsletter or something that they're giving back to you. And we know it takes a lot of time, and we're truly appreciative of that. So this is my last slide to just kind of talk about how we can increase participation and diversity. We've heard a little bit about those participant advisory boards. I think you're seeing that much more now, where researchers are actually reaching out even before they write their grants. to ask, what do you want to see us do? How do you want to see us conduct these studies? Having those recruitment materials that really reach out to your population. You're not probably going to want to be in a study if the brochure cover has an individual that doesn't have Down syndrome on it, right? So we need to make sure we're really tailoring our materials to the families we're serving. Having those community partnerships in place. Keeping engaged with your families. It's not something of coming in and just asking for them to contribute to the study and then, disappearing and not being there if they need help. All right, and then my final slide is just a slide discussing my funding. And then we also have the Yellow Crayon Fund at Emory, which we are very honored to be supported by the Joanna Stone family. And I'm not getting any kickbacks for this, but we had the presentation on the entrepreneurship. This shirt that I'm wearing today is from Grace Key. She was featured on the cover there. She has her own company and she's an amazing, truly impressive self-advocate. All right, thank you.